Thank you, everyone. I'm going to tell a little bit of a story of how Partners Health System, which is now MassGeneralBrigham, you'll see the initials probably interchangeably throughout my slides, so I apologize for that. We're still getting used to the new MGB branding. How the COVID-19 hotline came about. We have a weekly call with our Associate Chief Nurse Officer every Wednesday morning. And we meaning the ambulatory nurse directors and professional development managers at the Brigham. So that Wednesday morning, our boss, so to speak, charged us with pairing up into small groups and coming up with components of what would we need to put in place if we were going to stand up a call center in 3 days. So she divided us into groups. Laura, of course, was on informatics and technology with a couple other people. Myself and a couple of other professional development managers were charged with figuring out how do we orient the nurses, and there was a staffing component and that type of thing. So that was on Wednesday, March 4th. Right about the beginning of the rumblings of the whole Biogen conference, COVID-19 exposure in the area. So then the next day we met in person and we rated all of those discussions that we had and decided which was most important. Friday, I got an email and a phone call and said, we are starting a call center on Sunday and I would like you to help me lead it. So that is why I'm going to start telling the story and sharing a little bit what Partners did. So in response to the COVID-19 outbreak, MassGeneralBrigham quickly stood up 2 triage hotlines. One supporting MassGeneralBrigham patients and providers, which is the nurse hotline that I'm going to talk about, and another supporting the employees, which became an occupational health hotline. So the COVID-19 nurse hotline launched on March 8th. It was a Sunday. It was developed to guide and educate patients and providers about COVID-19. So we started on that Sunday with 8 operators and 1 clinical nurse lead. We had a lot of support. We were located centrally at Partners headquarters. So we were able to utilize some former computer training rooms that were quickly transitioned into call stations for our nurses. So we had a lot of technical and telecom support on site. By April, we had 40 to 50 operators daily, and I did not include, we had about 20 remote operators at that time and additional clinical nurse managers because we had several rooms that we were supporting at that period. But prior to this outbreak, Partners, now MassGeneralBrigham, had not utilized a centralized call center for supporting patients, providers, or employees. So what we're going to talk a little bit about, and Laura will go into a deeper dive into one of the offshoots of this hotline, is the evolution of the hotline, operation structure, feedback, and some lessons learned, because obviously this is grassroots and on the boots on the ground, so to speak. So the primary aim of the hotline when we were charged with starting it was to guide and educate patients and clinicians about COVID-19. So we ourselves had, to educate ourselves and get information filtered to us from our infectious disease specialists, from the CDC, and develop daily scripts and talking points to have as a guide for our nurses that were answering these phone calls. When I was looking at the different icons to throw on this, I did beg, borrow, and steal from some others. But then when you see all this little one here, I didn't want to get rid of these because it felt like it went from one patient calling in the home to the nurse communicating back and forth to providers and people at the hospital with questions and concerns, to multiple calls. And you'll see our volume and has increased exponentially. Another primary aim was to prevent patient presentation to an emergency room or hospital with COVID-19 symptoms and or to get tested. Because as the outbreak kind of hit the media in the greater Boston area, people were concerned about how could they get a test, how could they make sure they weren't exposed, and starting to filter out from that initial conference, which was kind of like our ground zero, so to speak. So the evolution of the scope of work at our hotline, our original scope was we were to answer questions about COVID-19, guide decisions about upcoming appointments as practices were deciding what to do with in-person visits, education and teaching. We educated in ambulatory practices and how to mitigate their patients. We had a lot of phone calls from physicians in the early stages asking what to do, how to protect their families, those type of things when it was still a little bit of an unknown. We were documenting in the medical record, including, routing or sending the messages to the clinicians, either as an FYI or to inform them of their symptoms or concerns about COVID-19. And then we would guide patients for testing. As the hotline, as the region reached the height of the COVID-19 curve, so to speak, the hotline did evolve. So patients were calling with potential COVID-19 symptoms that had to be triaged appropriately to various levels of care. So we were not only charged with like screening them to determine whether they met our criteria to receive a COVID-19 test or not, and giving them some general information about social distancing and COVID-19, we had to expand our nursing skills, so to speak, to be able to determine whether we're going to refer a patient for a virtual visit with their primary care as they were emerging and starting to build their telehealth platforms. We also developed a way to refer patients to what we have called Partners Healthcare on Demand. So what that would be is if a patient had some symptoms but probably wouldn't be seen in an urgent care or an emergency room because they also had a fever or a cough, with or without potential COVID-19, but they still needed to be seen, they had the option of being seen on demand on the same day. So we would also arrange those visits for them. So they had instant telehealth through our triage process. We would also determine if their disposition required them to go to our newly developed respiratory illness clinics or refer to the emergency room. So at the height of our call centers triaging cluster, we were sending probably 10 to 20, possibly 30 patients a day to the emergency room based on their symptoms, just through our central call center. We also launched a pilot connected workers program. So we were providing our nurses with the technology to work the call center remotely from home and still be connected to the call center application and connected to the clinical nurse leads to support them and to help them with any assistance they needed with triaging the patients or working through any of the documentation. And then, as Laura's going to speak to, we also supported a remote monitoring program and also evolved to provide outreach to over 10,000 identified at-risk patients in the MassGeneralBrigham system, developing documentation forms to assess social determinants of health, possibly put in some referrals and provide them with some education and touch points where they may or may not have been able to see or communicate with their primary care over this time where they were, the practices were not open. So the timeline, I'm just going to talk a little bit about the first few weeks. Like I said, the call center idea was first discussed on March 4th and we opened on March 8th. We've got some project managers assigned a couple days later. A week later, the Health hotline went live on that green flag, and I don't know why the date disappeared, but it was somewhere around March 14th. We had the remote call center pilot go live, so we had some nurses starting to work remotely from home. The ability to refer patients to our RICs, our respiratory illness clinics, went live a little bit later in the month, and our Partners Healthcare on Demand referral went live in April. The remote monitoring care companion program went live in April as well. And then, as you can see, here we are 6 weeks into our call center when we finally updated our IVR or our messaging scripting on what the patients hear when they call into the call center to include Spanish instruction. So I'll talk a little bit more about that in our lessons learned. I did skip a whole bunch of time here in May and June because our call center kind of steadied with our volume and our degree of severity of illness with our patients, but we did actually go completely remote with our call center nurses. So we have about 35 or so nurses working remotely as of July of this year. The evolution of our electronic medical record documentation. So we had to create a virtual department in our EMR and also distribution communication list and mailbox to communicate with the nurses. Initial documentation for testing obviously started on March 8th with a simple phrase that we used, but then after that phrase determined whether a patient needed to be referred for a test or not, required manual paging of our biothreats teams to make the arrangements for the testing. So that was filtered up from the nurses that were receiving the calls to the clinical nurse leads like myself, and we would have various different ways of reaching out to the different biothreats teams at the different institutions. For example, we would have to page one team at one institution, but phone call another institution in this way, and then put yourself into a WebEx type conference call at another institution. So the workflows were different and varied and time consuming to get from the point where we identified a patient was meeting our criteria for COVID-19 testing to getting them approved by a biothreats provider and getting the test ordered. So then we developed a triage form where there was some logic that linked to the form to optimize end-to-end referral order process, and we were able to place orders for the COVID-19 testing ourselves as nurses at the call center. And then we updated it to include logic to identify, based on patient symptomatology and how they answered the questions, it would prompt the nurses to consider referring them to a respiratory illness clinic or emergency room, and then they would assess their other comorbid conditions to make that determination of where they would refer that patient to. And then we are also able to capture our partners' health on demand recommendations and gather more data of what types of referrals we were making, how many tests we were processing through the call center. Operationally at the call center, administrative, we had project managers that were overseeing all aspects of the operations. We had on-site project managers to ensure operations and provide time-sensitive support, administrative support, EMR support, IS, telecom, all the things that you would think of. Our clinical staffing needs, we had our associate chief nurse officer, the one who I'd mentioned that kind of charged us with this at the beginning, was our liaison to senior leadership and helped drive decision-making for criteria for testing, for daily scripting, for changes and messaging that would come from the triage team of all the ID providers throughout all of the institutions that met together pretty much on a daily basis, and they would filter that information back down to us at the call center, as well as out throughout the enterprise, to make sure that everybody was on the same page with how we were managing and treating and processing COVID-19 testing and referrals and illness and that type of thing. Clinical operations managers for overseeing the operators and any issues requiring escalation. That was basically our role. We were considered like a clinical manager, nurse director, whatever title you want to call it. We were there overseeing the nurses on a daily basis. Clinical informatics managers for oversight of data, waving at Laura and Sandy. Thank you so much. We couldn't have done this without you guys. We also had a nurse director that was working with a staffing team to help us staff, because we were staffing from all, like Laura spoke about, we were pulling in nurses from all different institutions throughout the MassGeneralBrigham enterprise. Our staffing needs, we identified, obviously we needed nurses skilled in ambulatory triage. And I'll speak to that a little bit as we talk about lessons learned. One thing that really helped us was when we would have daily huddles with our project managers and with the nursing and with our, initially with the associate chief nurse, everybody that was involved at the leadership level for the call center. And I remember them saying to us, and Sandy can correct me if I'm wrong, what do you guys need for support? And like, we need people like that administrative support for clerical responsibilities, like just helping us with like capturing time cards, so to speak, signing in and signing out, things you wouldn't think of, capturing how are we going to provide them with parking and those type of things. And for the first week or so, the clinical nurse leads were doing all of that, plus managing the call center's clinical needs as well. So having that administrative support was huge. And we are so grateful that a lot of the project managers that were on our team were able to launch that so quickly. Some key performance indicators from the call center. Total number of staff with shifts. We had 362 different nurses come through the call center. Some of them only worked for a couple of weeks. Some of them worked the entire time. Some of them are still working with us now remotely. Broken down by the number of nurses per entities. But right now at the bottom, in the bottom left-hand column here, the number of staff working remotely, currently we have 36 total, with a core that were hired specifically just to work the call center, and some still supporting from various entities throughout MassGeneralBrigham. Our call metrics for the call center, total number of inbound calls, this was from opening day, so to speak, through yesterday. We had 84,800 calls come in. We handled 60,000 of those. It seems like a lot that we did not handle, but a lot of the times patients would hang up prior to being connected to a live person listening to the messaging. Some of the messaging referred them to a link where they could go do self-screening and guide them to other sources of information if they did not screen in for getting COVID-19 testing. And some of it was because of dropped calls or patients were waiting quite a while in the queue in the early stages of the call center. In the first couple of weeks, we were getting 2,000 to 3,000 calls a day,
Mhm.
and patients or callers, I should say, were waiting online sometimes up to 45 minutes
Yeah.
on hold. So it was very busy in the first few weeks. But you can see the number referred for testing through yesterday was 11,000. Respiratory illness clinic referrals, 1,300. Um, Total number with emergent medical record numbers created over 2,000. It gave us the opportunity to create a medical record number if somebody met the criteria for testing, and also met the criteria for us to create that record so they could start getting treatment for their COVID-19 and or get screened for the test themselves. When we were doing our outreach calls for patients, the initial slide said we touched over 10,000 outreach patients. The data from the more specific outreach calls we're doing now is 7,600, but prior to that number, we also did a smaller pilot with one of the other hospitals to call patients that we received lists from their primary care. So what the call center nurses would do is do an outreach call, call the patient, say, you know, I'm calling on behalf of your primary care doctor so-and-so. Do you have any questions about COVID-19? How are you feeling? Do you need education? Do you need a care kit? And if they said they needed a care kit, the care kit included masks, um, hand sanitizer,
Yeah.
instructions about COVID-19, and 8 different languages, and we sent those out. Social determinants of health referrals, we've generated 455 based out of those outreach calls since we've been doing those for the population health department at Partners. And this is just a view of what we get for data. I don't want to go into too much detail here, but I kind of grade out the occupational health data line. So ours is in orange for the nurse hotline. And you can see here we are in March with our spike in calls, 2,000 to 3,000 a day. And then we kind of flattened out a little bit in May and June. And it's picking up a little bit again. It's picking up a little bit again because people are concerned because everything's opening up. They want to get back out into the world. They need to get a test to go back to school. They need to travel. They would like to travel. There's been some large gatherings and then, you know, requests to have tests after that. So you can see that we've tracked inbound calls, answered calls, inbound call handle time, average speed to answer, abandoned calls, and then our referrals like we spoke of. And then we can look at it over a month. And then the last couple of weeks, you can tell by if you can see the dips in here, that's weekend. And then every Monday, we call it Manic Monday. We get, you know, at least triple the calls so we get on other days now. So we can start seeing some trends in current trends when we're looking at volume. We also will get a daily summary sent to us, so it breaks down like the number of calls per shift, the number of calls offered, answered, again, the same handling time, abandoned, and then we also get the information for the occupational health and return to work call lines, but we really just focus on our nurse hotline when we're looking at the number of encounters that were created, the number of patients, a number of outbound calls. Since we started doing some outbound calls with the program Laura's going to speak about, plus our outreach, we wanted to capture those as well. So we look at different types of encounters that were created and start to see what trends and how we can expand the call center going forward. It did have a governance structure. It was sponsored by a couple of chief nurse officers. You don't need to know the names of these people, but just kind of see how we designed, you know, the hierarchy here. And then we had our associate chief nurse that I spoke of that was kind of overseeing and being our liaison for senior leadership and any kind of messaging that needed to get to us that we could share with the call center staff. Our clinical operations managers, Sandy, myself, and three other nurses, I'm sorry, clinical data analysts. We had our project managers, operator staff, and then our ancillary support, which went into place within what, like 3 or 4 days, Laura? We had
Yep.
telecom, IS,
Yep.
workspace services, all supporting the nurses. So it happened like in a flash. Here's a quick slide about some feedback that we got from staff and patients. I want to say thank you to everybody at the call center. I had a family member who needed to be sent to Mass General after doing a virtual visit with a nurse, so I know how personally important this service is. Some quotes from the nurses from the call center. All of what nurses do so well has happened within the call center. We follow up with patients and connect them with the best possible care and resources. The call centers confirm the true role of the nurse in healthcare. We are the glue and really advocating for care for patients, whether somebody is clinically acute at the moment or may need care the next day or month. I can assess if somebody needs respiratory support right now or connect somebody who's facing homelessness next month with the resources they need. So that's a lot of the feedback that we got from the staff that was involved at the call center, and also feedback from clinicians and patients. Just to highlight some of the lessons learned, hiring nurses with ambulatory triage experience is essential, especially as the hotline transition to triaging clinical symptoms and determination of appropriate disposition. Having a minimal skill set and comfort with triage is important. The reason why I say this is that when we had those 362 nurses I mentioned that kind of filtered through the call center, some stayed, some did not. Many of them were redeployed from their areas because their areas were closed. So we had operating room nurses, we had endoscopy nurses, we had a lot of perioperative nurses, we had GI nurses, inpatient GI nurses, inpatient cancer nurses, oncology, I'm sorry, nurses. And they had varying levels of experience with ambulatory triage. Using your sense of hearing and your ability to communicate with the patient was something that we had to really work on with our nurses when we were in the height of the illness phase of the greater Boston area with the call center. Another lesson learned, rapidly changing developments and updates to documentation required real-time communication about workflow changes. So what that means is that our scripting would change every single day, sometimes twice a day. There'd be times that we would get a phone call from our associate chief nurse at 2 o'clock in the afternoon, put all the operators on hold and say, okay, now we have to do things this way. This has changed. This is our new criteria. This is what we need you to document. This is what we need to speak to. So some things happened in the minute, and most of the time we were updating our script every day at 7 a.m. and then making sure that all the operators had an update and training to what was new for the day within our MassGeneralBrigham system. We did recognize the need to develop initial instructions and multilingual resources for callers. Like I said, when I pointed out that flag of identifying the need to have some Spanish instruction on the incoming message for our call center, I think may have helped some of our abandoned call data early on. Due to the urgency of standing up the call center, training for operators was brief and non-standardized, so we do realize that formalized orientation and training is needed to sustain a triage call center. And we also have identified, especially now that we've gone 100% remote, that more training is required for remote operators. Our clinical nurse leads are there to assist them and help them with things that need escalation, but some things that we recognize they should have a little bit more experience doing in person at a call center versus doing them in their own home, in addition to being comfortable with the technology component of it. A staffing team and designated mailboxes need to keep up with scheduling, communicating changes. There's different needs with different nurses, communicating with the institutions and their nurse leaders back at their home base, so to speak. And staffing needs definitely were defined by call volume, which is driven by media, state news, and trends of the moment. So that could change again. We had like I said, the flattening of our calls in May and June and made some staffing changes, and now we're seeing an uptick again in July. And I think it's because of, recent changes in, like I mentioned earlier, things opening up, other events that are happening that have caused, the purpose of having some large gatherings and those type of things. So really depends on what's going on in the moment, and being able to respond to that in a staffing and workflow and process is important. Centralized call center implications for telehealth. An approach to telehealth nursing for diverse patient populations should be considered just based on our hotline experience to date. Using ambulatory telephone triage as a foundation, it can expand to include the remote monitoring program that Laura is going to speak to for various disease processes. And also we've identified that we can also provide that outreach support for population health needs. Just my last little slide is just a thank you to Sandy Cho, who was one of our clinical nurse leads at the call center. We were lucky enough to have Sandy join us from like early March to the end of May. And this is us celebrating her and thanking her for all her help, because she was instrumental in many of the components that were outlined on this overview of the call center slide presentation, which hopefully will segue into Laura's component of remote patient monitoring. Thank you.
Very nice, Lisa. Sandy was there almost every day for a while. Like a lot of us were there almost every day, 7 days a week for the first few weeks. And then after that, the schedules kind of, they were a little bit better.
if we have time, I did put a separate slide deck together, just some pictures from our call center at Assembly Row, if just more like, for fun and informative. But obviously questions, Q&A after Laura's done takes precedent. But if you want to, Mary, just let me know and I'll flip back after we're done.
Okay. Mary, you're on mute.
Love to see those at the end. Why don't we just transition to Laura and hear Laura's presentation? But maybe as we're taking Q&A, Lisa, you can kind of go through the pictures. That'd be fun.
Just trying to. Okay. Okay, can everyone see my screen?
Yep, looks good.
Okay, all right, perfect. Okay, so I am actually going to talk about our remote patient monitoring program that we implemented during the pandemic, and that the call center that Lisa helped established, staffed, and helped me implement this as well. Okay. So basically sometime in March, our command center actually decided that we needed to offer a remote monitoring program, and we launched this on April 20th. We've started a pilot with BWH and MGH with a goal to enroll about 50 patients after an inpatient admission for COVID-19. That was very successful, and we actually rolled it out at BWH at Faulkner, North Shore Medical Center, and Newton Wellesley Hospital. Next to participate were the BWH and MGH emergency departments. And basically all the monitoring was done centrally by the COVID-19 nursing hotline. And then we also had 24 hours a day, 7 days a week, physician backup coverage as needed. And so my presentation is going to review the evolution of our program, identify operation structure and key staffing needs. I'll just give a quick example of a case example. We'll summarize the findings, the program data and findings, and highlight some lessons learned. Okay. Oops. Okay, so our primary aim. So our primary aim originally, well, there was more than just what I've listed here. So we wanted to enhance safety of discharge home, reduce the length of stay, and reduce patient and provider worry. As well as once the patients were home, we wanted to prevent readmissions or presenting to the ED. And we offered this to all adult patients who actually had a patient portal and spoke English and Spanish, and they needed to be discharged home. They could be discharged home with VNA services, but they were not, and they could be homeless. But we didn't take any patients that were being discharged to Boston Hope or to any SNFs or transferred to Spalding Rehab or any of the other rehab organizations that we support. So the evolution of the scope of work. So basically, like I said, we started with 50 patients. I don't know why, 50 patients. Those patients answered two questionnaires per day. Every patient was sent home with a thermometer and a pulse oximeter. All patients received a phone call post-discharge 1. Patients were monitored in the program for 14 days. The nurses documented in a note format. Physicians were on call for backup and directly available for patients overnight. And we had a central supply managing group of people who helped with getting all the supplies to the patients that they needed, as well as trying to gather the pulse oximeters back from the patients. So as the program evolved, we actually changed the amount of times a patient got a questionnaire to once a day. We found that patients were not answering the questions twice a day and were doing okay, but that was also causing a lot of noise in the system. Nurses would need to respond to anytime a patient didn't answer an expected questionnaire. We actually, like I mentioned, we offered it to other inpatient organizations. We switched our pulse oximeter criteria to only give those to the patients at highest risk. And the reason for that is those pulse oximeters were $375 each. So we quickly ran out of them. And then we were also having a hard time getting the patients to return them. We actually established a centralized tracking of the pulse oximeters, and the nurses at the call center would, at the end of the program, would actually send instructions again and instructions reminding the patients to return the pulse oximeters, as well as in the last day, the final day telephone call that was made, they would remind them to return the pulse oximeters as well. We extended the option to extend the program to 21 days if the patient wanted to. We actually changed the nursing documentation so that it was, they were documenting everything in structured flow sheet fields for reporting purposes. We were actually, once we went live with those flow sheets, we were able to get more reports. We actually added the mobile response team, the mobile integrated response program for to offer to prevent readmissions or ED visits. We rolled out to MGH and BWH-ED, and that was, I would say, fair at best. And basically, we ended up sunsetting the program to new enrollees on June 10th, and then completed the program on July 1st. Okay, so how it works. Basically, what happens is the provider in the inpatient service would decide whether or not the patient met criteria for remote patient monitoring. They would actually reach out to their case management team, and there was, depending on what entity, depending on what entity the patient was coming from, sometimes it was case management, sometimes it was other ancillary staff that would do the screening to see whether the patient really was a candidate for the program or not. And those people were actually supposed to identify if the patient had access to the patient portal that was available through our EHR system, were able to utilize the patient portal as well. So at that point, an order was supposed to be placed in the system for our program. And sometimes both of those things happened and other times they didn't. And then the patient was discharged home. They were given a pulse oximeter, a thermometer, and the packet information. And sometimes that happened and sometimes it didn't. And the call center nurses were great with managing the patients that called and said, well, I don't have a pulse oximeter. I didn't get any information. So they did a great job. Then basically, once the patient was enrolled in the program, we had a report that we would run, and the nurses would call the patients on day 1 of discharge, and actually make sure that they had access to the patient portal, their patient portal. If they didn't do, they helped troubleshoot getting them access to that, and sometimes that worked and sometimes that didn't. If the patient portal, they couldn't get access to the patient portal, we ended up having to unenroll them. Some of the patients didn't want to be part of the program. They really didn't understand what the program was about. So at that point, we would unenroll the patient, and we would need to discontinue the orders and tasks associated with the program. And then basically what the patient did was they would answer a questionnaire once a day. They would put their pulse oximeter value in, their temperature, and then they would answer 4 questions. Are you feeling better? Are you feeling short of breath? Are you having trouble breathing? And I'll go into all of those questions. So they would answer those questions. And if they had worsening symptoms, abnormal vital signs, or if they didn't answer the questionnaire, the nurses would get a prompt in the system that said, the patient is either worse, vital signs are abnormal, or they didn't answer the questionnaire. And at that point, they would call the patient. And so that's why actually, so we started with the questionnaires twice a day. And that's why we went down to once a day, because the fact that the patient would think that they had answered the question, they didn't really understand that they needed to answer the questionnaire twice. So there was a lot of noise in the system, which created more work for the nurses. And then at that point, the nurse would triage. Like Lisa said, the nurses actually needed to be actually fairly nimble and comfortable with their triage skills. And if they felt like the patient needed to get escalated to the provider, they would actually route the message in the EHR. I know it says call here. Sometimes they called, or sometimes they just routed the message, or they paged, and then the provider would look at the patient's EHR, and there would be a conversation back and forth between the nurse. And if they stayed if they actually got readmitted into the hospital, they were unenrolled in the program at that point. But if everything went all well, they could stay in the program on day 14 or day 13. The nurses would call the patient. The patient would decide whether they wanted to enroll in the program or continue enrollment for another 7 days, or unenroll. And the nurses also sent messages via the EHR into the portal for this information. And what else did they do? Yeah, and as the program, actually, as we improved in the technology and the build of the program, more of how it works was more automated. And then here you can see after either 14 or 21 days, the patient ended the program. Okay, oops, I must have went back. Okay, this is the teaching packet material. Packets were available in English and Spanish, although we did have some other patients that spoke other languages, primary languages. They just had a significant other enter the data into them, into the system for us. And actually this video, they did a little video. You can see the video in the corner here of Dan Henderson, one of the physician leads in the project. He did a video showing everyone how to do their pulse oximeter. And these were our operational needs. We had a remote patient monitoring central operations program. We had 2 project managers, 3 physician leads, 2 nursing leads, which is myself and Diane Sousa, and then a part-time administrative support for the central pulse oximetry return process and decontamination, and then mailroom staff. So this group met actually daily for 30 minutes initially. And then as the program went underway and, kind of we worked out the kinks, we changed that to 3 times a week. Also, we put together nurse-driven protocols, as well as, the tip sheets and the manual and the standing operation procedures. So that's what came out of the central operations group. Then the remote monitoring, the remote patient monitoring central staffing, they had 2 nurse leads, which there were 2 leads, like I consider Lisa and Michelle Uchi the leads, and then kind of under them were Sandy, that they're probably more equivalent. Sandy was their equivalent. And then we had another nurse, registered nurse, who started out as a staff nurse, but then became very competent and using the system and actually just knowing what to do. And so she actually led as well. We had 13 nurses and 16 physicians. And then this site-based implementation team, that was basically, this was an inpatient, that they were on the inpatient side of things, operations side of things. And so I thought I'd just kind of go through a quick patient example, and then we'll go over the data. So basically, this patient was discharged home on 5/7. The nurse called day 1 of discharge to make sure the patient had access to the portal, introduced the program again, made sure they understood what the program had to offer. And then on the next day, the 8th, the patient responded to the questionnaire, and the SpO2 was 90% on 2 liters. So therefore, that came into our EHR, and the nurse actually picked up the phone and called the patient, and then did some triage with the patient, and needed to escalate that to the provider, who actually needed to review the patient data. And it was also a Friday afternoon. And so basically, that's when we used our mobile response program, mobile integrated health program. So we sent out the paramedics. They were able to assess the patient. They reassured the patient. I mean, this is global what the program does, but this is what they did for the patient, and the patient was able to remain at home and did not need to come into the emergency room. Okay, whoops. So these are our numbers. So for the 5 organizations that participated in this program, we had 1,356 patients discharged with COVID-19. Of those, 295 patients were referred for our program. Out of the 295, 225 patients were enrolled in the program, and 181 of those actually completed the program. So out of the 295, the reasons why those patients didn't end up enrolling was some of the patients didn't have access to their patient portal. They really didn't understand what the program was all about. And some of them, we didn't have an explanation of why they didn't get enrolled, just because we didn't have a discrete field to capture that data for some of the patients. Of the 225 that were enrolled, 44 did not complete the program. 30 were lost to follow-up. 5 opted out of the program before completion, and again 9 we didn't. There was just other, and there was no explanation and on the fields associated with that question. So the other specific data. So let's see. I just want to make sure I'm covering everything. Yep. And let me get. Okay, so these are our patients' characteristics and demographics. So pretty split for male and female. The median age was 51. The language, majority were English, but there were Spanish and other languages. The race was 22% Black, 38% white, and then other, are not available. And then our ethnicity broken down, and then actually medium income by zip code. And this was very important to MassGeneralBrigham. We got a lot of questions on whether the program was meeting the needs of a racially diverse population. We did have one provider file a safety report because there was a misunderstanding. They thought that it was only being offered to English-speaking patients. We really had to look at these numbers. The program characteristics, like I said, we had number of patient days in the program were 2,295. Number of questionnaires submitted, 2,000. Program duration per patient day was an average of 12 days. The number of questionnaire responses was 11 per patient. Patients that completed at least one survey was 210. We had patients that triggered an alert of symptoms or vital signs were 72 out of 210. And then 15% of the questionnaires fired an alert. The nurses made 868 outbound calls, which for the number of alerted, alerts that came into the in-basket that were related to symptoms or abnormal vital signs, that was a lot. But there, like I said, there earlier in the presentation, there was some noise associated with the patient questionnaire. So that's probably why there were that many telephone calls made, but there really didn't need to be that many. And then just the escalation questions. And then these are our readmission status. So basically, 94% of the patients were able to remain at home. 4.9% went to the ED, and then 1.3% were admitted. So that was pretty good. This was the program findings. So we felt that the implementation and impact of a hospital-based remote monitoring program would significantly decrease ED or hospital readmissions. We found that among patients who completed at least one questionnaire while enrolled in the program, 66% did not create a symptom alert that needed manual follow-up. The remote patient monitoring program for patients with COVID can provide broad monitoring without the need to directly contact the patients after hospital discharge. And we felt like we demonstrated a scalable mechanism for monitoring patients with high risk. Sorry, my battery's running low. With high risk clinical worsening, scalable for monitoring patients with high risk. I left out a word, high risk clinical scenarios. And our lessons learned, we felt like we needed tight integration and communication with a dedicated build team to allow for the program to adapt and quickly grow, which actually we really had a good working relationship with the folks that built this application, and turnaround time for anything that we needed was pretty quick. This was a new program. We took foundation program and quickly realized that we needed to make some significant changes to the software. And you know, the build team were learning as they went, but they really did a nice job. We needed a well-defined site-based implementation team is necessary for successful rollout. We had some hiccups along the way with people in the with teams in the inpatient setting, realizing that they could offer the program. The patient needs to be enrolled in the portal prior to discharging the patient home in order to make this successful. The nurses actually in the call center spent a lot of time helping the patients enroll in their patient portal. We decided that the patients don't need any more than one questionnaire a day. And centralized processing for monitoring is a workable tool. We needed to make sure that we track the pulse oximeters throughout the stages. So yeah, we lost some of those, and need to identify owners of workflow for supply team. And we actually just need to evaluate what the barriers were to enroll in a digital health program. We need to actually think about non-English and non-speaking Spanish patients when we roll this out again, if we ever have to roll it out again. And I'd like to say thank you. This is our RPM Central Operations team. I highlighted Avital Dishron. She actually was the project manager. She kept all of us on task. She did a phenomenal job. I did not highlight Sandy's the way Lisa did, but she was instrumental in making sure this program was a success.